Hello. Hello. Yeah. Hello.
Yes, sir. Yes, sir. We can hear you.
Yeah. I just wanted to check if I'm being audible and if the slide is being visible or not.
Yes, it is visible. Yes, your slides are visible. You can go on to the full mode, sir.
Yeah. 1 minute, please.
Yes, yes. Please take your time. No issues.
Just give me a minute's time, please. I'm not able to get this to full mode. Just give me a minute's time.
No issues. No issues. Take your time. No issues. Yeah, it's perfect.
Can we start?
Yes, yes, you can.
Okay, so let me start by welcoming everybody to this lecture on this afternoon. Now, at the very best of times, these lectures are difficult to attend. The post-lunch session in the afternoon, I really don't know how many people are wanting to hear to anything in the first place. So normally, I like to think like I was introduced by Dr. Pushkala before. This thing is, I normally like to categorize the listeners into 3 stages. The first stage, they try to pretend that they are listening while they're actually thinking about their Facebook or Insta or whatever else they are thinking about, which I cannot tell you in public now. In the second stage, that pretend starts becoming a little less and the mind is wavering a little more than what should be. By the time they reach their third stage, they've stopped pretending and they are not showing any signs of even wanting to listen. So the difficulty that I am having now is with these webinar series is we really don't know when people are getting into that stage 2 and 3.
Excuse me, sir. I think in a way it is better so that you can continue talking whether people are listening to you or not. At least 10 of us will be listening to you, because in reality the same thing will happen, but it will be in in person, and it will put you off. So now that will not happen. So you can go on speaking. At least 10 of us will be there to listen to you completely, sir.
So I am feeling sorry for the 10 of you.
No. Why should you feel sorry? We are happy to listen to you, sir. At least 10 benefited out of the crowd.
Yeah, thank you. So
please go on.
So the topic today, the title is periodontal therapy. Now, whether it is success or excess. So what I am trying to say here is, does this periodontal therapy work well from everybody's point of view, or do a certain set of people feel it is being excessively done without any real benefit? So we'll make it into 3 categories of people. One is the general dentist. Now here I will include all of the dentists who are from other specialties as well. One is the periodontist and the other is the patient. So for me, treatment should be considered successful if all 3 are happy. Now, if one is happy, especially if the periodontist is happy and the other 2 are unhappy, I think you can probably consider it excessive treatment. So I am trying to show 3 or 4 clinical scenarios that you will meet in everyday practice and try to tell you how the patient looks at it and how the periodontist looks at it and how the general dentist looks at it, and see which part of this is considered successful and what becomes excessive. Okay, so let's just a brief recap on what happens when the perio patient actually walks in. Now, what the general dentist is thinking is, I must keep the patient happy. I must pay the EMI for my audit. Okay. What the periodontist is thinking is, I must keep the patient happy. I must keep the clinician happy, that is the general dentist happy. And I must also pay the EMI for my Hyundai. Now the periodontist is a poor fellow, so he can't afford the audit. The patient, on the other hand, what the patient is thinking is, I must escape from both of these fellows, pay as little as possible, do as little as possible. If possible, go to Baba Ramdev and get my treatment done. So the difficulty is for all these views to converge together and get a successful outcome. Okay, so the problem where we start with is, one, either with the definition of the disease, the diagnosis of the disease or what the treatment outcomes are. So we start with the first one, definition. For a patient, there is no confusion at all, because for a patient, periodontal disease simply does not exist. Yes, for him, he defines it very simply. There is no such disease. So you will find people who come who have teeth that are very, very mobile. And when we unwisely ask them, what is your problem? They will say, when they are saying that illa, the mere action of their tongue touching that upper incisor will make the incisor go out of the mouth and come back in. Still, they will say, I have no problem at all. So from a definition point of view, the patient thinks there is no such thing as periodontal disease. For a general dentist, again, periodontal disease is one of those diseases which for him as a student is always associated only with tons of calculus on the patient's teeth, which he doesn't like seeing and doesn't like removing either. So his idea of periodontal disease is a rather hazy problem, but somewhat associated with the start of the problem or the reason why the problem is there. The real difficulty is, after so many years of periodontal diseases that we have encountered, periodontists still argue among themselves about what is the definition of periodontitis, how do we classify periodontitis, and we still don't have a good consensus on it. This is why this disease is poorly defined and poorly diagnosed. Okay, because the specialist is not sure of the definition, everybody else is sure of it. So there we have a problem. Okay, and then you get to the diagnosis. General dentists like all those diseases which they can diagnose by just seeing. They don't like to diagnose any disease which they have to either examine with their mouth mirror or use any other instrument. So for them, caries is good because you can see caries. Edentulism is good because you can see edentulism. Malocclusion is good because you can see malocclusion. But periodontitis is not so good because you have to actually sit and probe for it. Now, for some reason, that probe, which is at most 1,000 rupees at cost and a very easy instrument to procure, no general dentist likes to buy. In fact, you will find a thumb rule, I will tell you, and don't quote me on this. I don't think there will be 15% of all the clinics in the city which have a probe with them. So diagnosis becomes difficult from a general dentist point of view, because they don't like to actually do any examination. For a patient, diagnosis of periodontitis is always something that they think this is something that the general dentist is saying, or something that the gum specialist is saying just for the sake of making money. He doesn't believe in it at all. Right? Then the third thing is the treatment outcome. Now there, again, we have a problem. Usually treatment outcomes that are visible and that are something that can be easily seen are best appreciated by both the patient and the dentist. In perio disease, one difficulty that we'll have is, while the periodontist is able to easily appreciate what the treatment outcome is, and he may be happy with it, it is very rare that the patient is actually able to appreciate that there has been a visible difference. Okay, so this is the reason why periodontal disease is somewhat underdiagnosed and untreated, because there is a somewhat poor definition of it from the general dentist and from the patient point of view. Diagnosis is not that easy to make for a general dentist in normal circumstances. The treatment outcomes are not easily appreciated by the patient. Okay, so whenever you have a disease where both the definition and the treatment outcome is best defined by the expert in that disease category rather than the general dentist, you have a problem. Okay, so I'm showing some clinical situations where you will see this. The goals of therapy, we all know this. I think anybody who's done perio will tell you the goals of periodontal therapy may be into two. One is to arrest disease progression, and the next one is to regenerate the lost attachment apparatus. Okay, so it is a somewhat hazy definition. Now, what it actually means is periodontitis is a chronic inflammation. There is no resolution. And like many other chronic inflammatory diseases in the human body, there is no cure. There is only control. Yeah. So Rheumatoid arthritis does not have a cure. Simple, or what you would think common diseases like diabetes mellitus type 2, there is no cure, there is only control. So what everybody must get it in their mind very clearly is periodontal disease is not like caries or pulpitis. It is more like diabetes. It is a chronic inflammation. There is no cure, there is only control. Now what happens is when we say we are arresting disease progression, we are trying to stop the progression of the chronic inflammation. We are not getting it back to health. So what is gone is gone. We are preventing further loss, that is all. So when you find a periodontist who is actually diagnosing the problem and telling the patient this is the state, and he's saying there is no cure, we can only control it, usually by this time the general dentist starts thinking, yo, it is time for me to change my periodontist. Now, this fellow is saying there is no cure. By this, if I keep continuing with the same periodontist, I won't pay EMI for my ERD, and I will start having to come to my clinic in a cycle. So this is the problem that the periodontist faces. If he goes around telling the patient that successful outcome of periodontitis is not dependent only on the periodontist skill, but also on your maintenance, most people don't like it. Okay, then the second goal, regenerate lost attachment apparatus. This is, of course, I think any periodontist who is listening to it or who is unwise enough to listen to this lecture, we all know this, that we'd like to get back cementum, we'd like to get back periodontal ligament, we'd like to get back alveolar bone. To be more specific, we would like to get back acellular extrinsic fiber cementum, perpendicularly oriented periodontal ligament fiber, and alveolar bone up to a level of 2 millimeters apical to the CEJ. This is what we want. Unfortunately, this histological ideal is very difficult to achieve. There has been to date, in spite of 40-50 years of research, there has been to date very little literature which has shown this actually happening. Okay, now we get back to this once again. You will find perio people take mostly because they have not got endo or ortho or surgery. Okay, so the reason I'm saying this is, now the fellow who's joined perio also is a little confused. So what he does is, he or she. So what he or she does is, he or she will talk general dentistry to the fellow periodontists, which they shouldn't be doing. They should be talking proper perio to their other periodontists, and they will talk perio to the other dentists. Okay, so which means they will go and tell the other dentist that, look, if you do regenerative periodontal therapy, we are not getting back histological new attachment. Can we get the, yes, okay. So what the periodontist tells the other general dentists are that you do not get back histological new attachment apparatus. Okay, you always remember, you don't regenerate pulp either. Okay? What everybody does so far is you are debriding whatever necrotic pulp tissue is there, and you're filling it with some foreign material, either gutta or whatever else. So there is no regeneration of pulp. So you don't see endodontists going around claiming that endodontic treatment is a failure because pulp doesn't regenerate. Unfortunately, our perio fraternity become very scientific over it and go around telling the other dentists, it is okay if you say this to a fellow perio professional because we want to get the ideal if possible. But what this person does is, he goes around telling the other general dentists that, look, periodontal therapy, even if we are able to regenerate, we don't get back histologically either cementum, periodontal ligament, sometimes we get alveolar bone. Yes, so you go around saying this to the wrong person. What you are saying is the ideal is not achieved. Not that the treatment is not successful at all, but what the other person is hearing is there is no use doing regenerative therapy. So the point I'm trying to make is, although the goals of periodontal therapy are well known to the periodontist, the language that you use and the impression you convey about what the treatment outcomes are not the same. It is okay to keep this within the perio fraternity. Do not go around saying this to everybody in the sense that perio treatment doesn't work. Okay. Right. So we'll start with the first one. Now you will see any number of patients who come like this. Obviously, tobacco stains. Obviously, there are some gingival inflammation. Now, this person, you will find he has come in just for scaling. So he gets the scaling done. The patient is happy. The general dentist is happy. The periodontist is happy because at this point, there is no need for any perio work at all. And he or she is not called for treatment either. So on this patient, there is complete success. So nobody thinks it is excessive treatment here. Everybody is happy. The patient is happy, the general dentist is happy, the periodontist is happy. Right? Now this fellow, the same thing, when you see somebody who has this kind of calculus deposits here, this is again a very common problem that you will see in India. All right. Now the treatment for this, first scaling is done, general dentist has done the scaling, and this is what you end up with. Right? There is not too much of periodontal loss. It's not as if this tooth is going to fall away because of lack of support. But in this case, the patient is not so happy because the patient thinks now he's developed gaps here where he didn't have them before. The general dentist is not so happy because the patient is unhappy. Right? Now the periodontist, poor fellow, is also not happy because this one is difficult to treat. Although it is not severe, it is difficult to treat because now you're looking at either a class 3 or a class 4 recession, which doesn't do well with treatment at all. Right? So this is one of those patients who are unfortunately far too common in our parts of the world, where after the outcome of basic periodontal therapy, I repeat, after the outcome of basic periodontal therapy, that is just phase 1, which is just scaling or root planing, you don't find too many happy patients, too many general dentists who are happy, and no periodontist is happy. So this is one of those problems where success itself is very low. But nobody thinks it is excessive treatment because all you've done is non-surgical periodontal management. Now, for this patient, this is for the general dentists who are listening. If your periodontal consultant is telling you, we'll do this, we'll do that, we'll try and regenerate the bone here, we'll try and get back complete root coverage, that will be excessive periotherapy because it is very difficult to achieve in this patient. As long as you know that you are doing some procedure to try and prevent further recession, that is not excessive. Now, that will have yardsticks of success, which we will define it at a later seminar perhaps. But if you are going to manage this non-surgically, that is not excessive. If you are going to manage this by, say, placing a free gingival graft or something else to try and prevent further recession, that is also not excessive. But if you are going to do therapy to try and regenerate this lost tissue here, that is going to be excessive in today's world. I don't know what is going to happen tomorrow, but in today's world, it will be excessive because it is not predictable. Okay. This one, now this is our favorite fellow, the guy who comes here weighing 70 kilos, of which 5 kg is this calculus deposit. So he comes in, gets the scaling done, and goes like this. From what is a mouth looking like this, he's looking far more healthy. But even this fellow is not so happy after treatment because he thinks these gaps have appeared. Right? Now, he is saying, I don't want this gap, to make it all right for me. So he is not very happy with the basic scaling so far. The periodontist, when he comes and sees this patient, the first goal is somehow we should avoid fainting from the smell that is coming out of his face, of his mouth. Isn't it? So if that first goal of not fainting from the halitosis, if that is achieved, then he thinks I have done something, then he thinks he is successful. Right? Unfortunately, again, there are not too many treatment procedures that this patient is going to benefit from. There is already recession here. Again, 3-4 grade. There are no probing depths, so there is nothing for the periodontist to treat. So the fellow is unhappy. But what happens is the general dentist now is happy with this patient because now he said, okay, I'll fill these gaps by doing root canals from here to here, placing crowns in all of them. So the general dentist is happy. Right? So this is a patient for whom the general dentist is happy. The patient is happy after the restorative outcome. The periodontist is unhappy because he is thinking or she is thinking that look, the problem basically was that there is some periodontitis that has got attended to by restorative measures, not periodontal measures. Okay. So this is the first set of patients for whom the basic problem was that there is inflammation because of a lot of local factor deposit. You will find in all of this, there is no happiness from the periodontist's point of view because most of the treatment required only non-surgical management. So there is no excessive therapy from the periodontist side in this. However, if all of this is being managed only with restorative measures, the periodontist is going to think it is excessive because all restorations from our point of view are going to increase the tendency for gingival inflammation. And for somebody who gets these tons of calculus deposits easily, you make restorations and all this, they are going to attract plaque like nobody's business. Okay. For the next set, again, we've put the set of patients here because these are also things that do not require probe for the basic diagnosis. You can see recession in all these teeth, isn't it? It is upper one here, here, in these patients, recession in all these teeth, recession here, recession here. Again, now if the patient is given treatment options for all this, most patients are unhappy because many of them don't have any symptoms at all. Yet this patient came with absolutely no symptoms. This patient came with absolutely no symptoms. This one wasn't worried about the spaces. This one didn't have any spaces to worry about. This person had some sensitivity. Right? So sensitivity, no symptoms, no symptoms. So he's come for correction of the sensitivity. This person has come for a routine dental checkup because somebody else told him, why don't you go and get it done? This person also has gone for a routine dental checkup. Now the problem is this patient, scaling was done, so he was happy with that. But the sensitivity that was there before the scaling has got done, it increased after scaling, because it always happens. When you have this amount of recession, when you have calculus deposits on cementum, you will always have sensitivity after the scaling, which is probably a little more than what was before it. Okay, these patients didn't have anything. This patient developed mild sensitivity, it went away. So in both of these, the patient is happy with the treatment apart from the mild sensitivity that was there. The general dentist, a little unhappy with the appearance, okay, because he feels the recession is there, why don't we correct it? He feels the spacing is here, why don't we correct it? But for some reason, recession never gets treated well in India, because the treatment options that the Perio offers for this generally is a connective tissue graft on the palate. So for most patients and for most clinicians, it looks like it is excessive therapy. For two teeth which have shown some what is considered minimal recession, which are reasonably asymptomatic, most clinicians think this connective tissue from the graft is a rather morbid procedure. Right now, from a Perio point of view, for the periodontist, CTG is still the gold standard. Okay, there is no argument in literature over it. If you can take a connective tissue from the connective tissue graft from the palate and treat this, both of this will do well. This patient will not because of this spacing. This patient will also do well with grafting procedures. The only problem is there are far too many teeth involved. You may not get enough graft for all of them. Okay, but this one will do well. Now the problem here is the CTG is one of those procedures which the periodontist is happy with. He feels the success of treatment is good, rightly so. But from the patient's point of view and the clinician's point of view, it looks like it is excessive therapy. Okay, but actually from literature it is not. Right? Because CTG is the gold standard. Okay? And what is the need for this therapy? Right now the patient is asymptomatic, but exposed root surfaces are going to show hypersensitivity or root caries at one point of time. Otherwise, it is going to progress more apically, and from then on, the success of CTG starts going low. Right. Now, this is the other patient. Sensitivity, you have all these root exposures. Patient has come complaining of this. Just like this fellow, you can see complaint here. Now our general dentist has a simple formula for all of this. All of these are considered class 5s and filled with restorative materials. Okay, patient is happy, general dentist is happy, periodontist is very unhappy. Because here problem actually is the patient has lost cementum, has lost periodontal ligament and lost alveolar bone. But the treatment that was done is restoration, which is not what should have been done. What should have been done is you should have done root coverage procedures whereby the gingival margin should be coronally displaced up to this level. Again, one of those things which get far too less as far as the Indian scenario is concerned. Right now, this patient, again, I'm showing this, you will find this patient got fillings done in all these teeth. This happens far too many times in India. Because why it happens far too often is because one thing, for the patient, it seems convenient. To general dentist, it feels convenient. Yeah, because there is no morbidity to it. It doesn't look like a surgical procedure. So the whole thing goes off well. But unfortunately, the problem is if you make restorations like this out here and extend it up to the base of the recession, plaque that will attract over these restorative materials. Remember, this patient has had calculus, which is why this recession is there. For all of them, the tendency for plaque accumulation will be more on restorative materials when compared to enamel. So if he formed plaque on enamel, definitely he will form it on the restorative material also, which means the tendency for inflammation will come back, tendency for further recession will go. So what happens here is once the patient comes back the next time with more recession than was there the first time, and there is a gap between the restorative margin and the gingiva, they will do again filling. Whatever gap is there, that also they will fill. So this becomes a continuous affair for a long time. So what should have been actually treated periodontally gets treated restoratively. So it seems like successful therapy, but when the actual periodontal therapy is given as a treatment option, both patients and general dentists tend to view it as somewhat excessive. Now, that is an unfortunate reality of Indian practice. Right now, this person again, it is the same thing. Right. So if you can see, if somebody starts getting recession treated when it was like this, right? This is the cement-enamel junction. The gingival margin has gone apically. There is recession here. Look at the treatment result. All of this works well. At this stage, if recession is treated, it works well almost all the time. The success is very, very, very high. Okay. Do not think it is excessive therapy simply because a graft is suggested. Now, if you are worried about the morbidity from the palatal graft, I assure you it is not like older times. Most perio people today are adept at doing it. There was a time when palatal grafts were not too much in vogue in our region, but it is not so today. There are many people who are well trained who will be able to do the grafts well. Even then, if you are still worried about the morbidity that the patient is likely to have, there are many other options available. You don't have to do a CTG alone. There are many allogenic grafts available. Still, treat them by periodontal grafting procedures, not with restorations. Okay, even if it appears to be an easier therapy, and even if it is appearing as if periodontal therapy is excessive here, that is not the case. This patient has a perio problem and it should be treated in a perio manner. Right? So what I have said so far is two things. One, where you had a lot of calculus deposits and you only saw calculus, you didn't see the root surface exposed at all. One, where the root surfaces were exposed without calculus deposits, but both those cases, there was no need to actually examine. So visually itself, you know this was the problem. Right? This set of patients, on the other hand, there. You can see this strange instrument. It's called a periodontal probe. And I'm calling it strange because it is one of those lasting mysteries in our part of the world. Now, every third year, final year student has this with him or her, because all of us tell them to buy it. So when you are in the third year, you have this instrument. When you are in the final year, you have this instrument and you are taught how to use it and all that. But the minute you've finished your BDS and you've gone and joined some other specialty, this instrument seems to disappear. for the rest of your lives, this instrument remains hidden somewhere. Right? And the problem is classic periodontitis that is associated with the pocket, you cannot diagnose without this. Okay, the diagnosis of periodontitis is made for this patient on the radiograph. But what you will see here is what is visible on the radiograph is much lesser than the actual problem. So the probing depth actually has gone up to around, see, you can see this here, a deep probing depth, which is somewhere here. So the radiograph through which most periodontitis diagnosis is made, simply because it is easier to make it that way, does not show you the full picture. It is a two-dimensional image, we all know. It is also indicative only of past disease activity. So the current disease or the ongoing periodontitis is best detected with a probe. Now these are things which I am sure all of you would have heard in your undergraduate days, but it is forgotten very easily. Right? So the more or less use this instrument. It is very easy to buy this because it is not an expensive instrument. Easy to use it as long as you use it the right way. Right? So you made the diagnosis and you've seen that is a pocket. Now what happens after treatment? You call the periodontist, you treat it. So this is the kind of bone loss that you will see. Yeah, horizontal bone loss. Flap is done, but the flap procedure also only arrests disease progression. You can see the bone loss here, it doesn't come back. So nobody is saying that horizontal bone loss can be regenerated predictably so far. We are only able to contain the disease process. So we can't make it come back to normalcy. So we are only saying, even with the flap procedure, we are reducing the probing depth. We are arresting the disease progression. We are not bringing back the lost attachment apparatus. Right. So we'll sit with this for a minute. So a regular patient who walks in looking like this pocket is there. Patient has come because there are some mild symptoms that he or she is experiencing. Maybe there is some mild bleeding when brushing, if he thinks about brushing. Maybe there is some indication of food getting caught in between teeth. Maybe there is some mild pain on mastication. So these are the usual symptoms that the patients exhibit when they come to you with a pocket. And nothing very severe, nothing that the patient can't live with. Right? Unfortunately, on diagnosis, it has become a rather severe problem. So we are telling the patient, look, this is not manageable by non-surgical methods. You have to manage it surgically only. You have to raise a flap. You have to debride the tissue. Only then it will become better. And the procedure is done. Okay. Now, post-operatively, this patient is going to look pretty much like this. Okay. He will not feel any visible difference because it looks the same. What happens to the general dentist? He has not probed the first time. He will not probe post-operatively either, he or she. I am just using he figuratively. Don't think I have this one against it. I'm just using he figuratively. It is both he and she, right? So he is not probing it post-operatively either. So he also thinks there is no difference. It looks pretty much the same. The periodontist is happy because the probing depth has now reduced from what was 8-9 millimeters to 5-6 millimeters. So he thinks the treatment is successful. Unfortunately, this is the big problem that we have, that when patients report with pockets and when pocket reduction has gone on well, only the periodontist appreciates it. Right? The periodontist thinks it is successful. The patient thinks it is excessive because there is no difference at all to him visibly. The general dentist is not so sure what has happened. Some treatment has got done. He or she is not thinking it is excessive because they all heard of this flap, but he or she is not sure whether there is any actual improvement or not. Right. So it has been many years and many people who told me, look, this is the problem with the flap, because nobody appreciates the difference. Visibly, it looks the same. The gingiva looks pretty much the same before and after treatment. Now, how do you educate the patient that there is some improvement? Now, my answer to this is simple. Now, you imagine a patient with hypertension. Imagine a patient with diabetes mellitus. Imagine a patient who has excessive cholesterol levels. Now, many of these patients are asymptomatic. Isn't it? It's not as if they come with, many of them have got diagnosed on routine checkups. So they know they are hypertensive, they know they are diabetic, they know they are hypercholesteremic, because they know what the normal level of BP is, they know what the normal blood sugar would be, they know what the normal triglyceride levels are. Isn't it? So the problem that we have made here is we don't have the habit of giving patients a periodontal chart. Okay, and now in the more advanced worlds, as they call it, if you can call it advanced, they all give you charts which will tell you you have pockets of 5 millimeters, 6 millimeters, 7 millimeters. So they have this chart with them, just like how you get records of 150 by 100 BP, which the patient knows is excessive because he knows the normal value. If the patient were educated that 3 mm is normal, 6 mm is not normal, that more than 6 you have to do a flap, then things become easier. Now, many white people know this. They have been given these charts. They know that 3 mm is normal, 5 mm is not normal, and it is something that requires treatment. The difficulty that we have here is we have not got used to the habit of making charts and giving it to the patient and educating them that anything that is over 3 millimeters probing depth wise is abnormal. It may be a pseudo pocket, it may be a true pocket, whatever it is, an excessive probing depth is there. Right? Now, if we tell the patient that this is normal, over a period of time, they will get educated, because what happens? Hypertension also is not symptomatic. Diabetes is also not symptomatic. Now, it is easy to say that yes, they can be life-threatening and this is not, that is why they are doing it. But with time and effort, if charts are given regularly to patients, and if these charts will mention what the probing depths are, they will be able to appreciate that it is normal, it is not normal, and what it was at the time of starting treatment, and what happened in terms of improvement after the flap got done. Right? I know we don't do it. Now, whose fault is it? Unfortunately, the major chunk of the fault should lie with the periodontist, because it is the periodontist who has not educated the dental dentist, and that is why the patient has not got educated, that the need for recording the periodontal status and giving it to the patient is paramount. That education has not gone on properly. So I am hoping if people who have heard this, at least 2 of you start making charts and giving it to the patients and telling them what their periodontal status was, things become easy. Now, why don't the periodontists do it? One, because they are lazy. So you need to probe 6 sites on 28 teeth. That's a long time consuming process. It becomes difficult. So if that is the problem, what you can do is at least give a chart where you will mention only the deep pockets. You don't bother writing everything. Okay? Do not bother about writing 6 sites. At least write 4 sites. Okay? Because then they will have some idea of what it is looking like. Hey, don't bother writing the PD and Cal both. Just give the probing depths. Enough. In some case, to the patient, I'm saying, not for you. So, in some way or the other, patient has a record of what his pathology is. The problem is, if the patient doesn't know there is a normal value and doesn't know the normal value has exceeded by that much, how will they know that improvement has happened after treatment? So more than anything else, this is one reason why I feel that even the regular flap procedure that we do, which is kind of like a bread and butter for the perio fellows, even that some people consider it excessive. But there is no way you are going to say that tooth planing or open flap debridement is excessive therapy, because in our country, the prevalence of periodontitis is very high. 25-30% is the global standard. Our patients, our country, the prevalence is, I guess, more. We don't have rigorous data, but my gut feeling is it is a little more. So you imagine 30% of our population, how many patients have periodontitis? Right. So the point is, again, there is no question of flap procedure being excessive. It is something that has to be done. The probing depths have to be reduced, because only if the probing depth reduces, you will have less plaque, less dysbiosis, less disease progression. The only way the disease progression is arrested is by having shallower pockets. Get the pocket depth to 5 millimeters and lesser, patient is able to maintain it. Okay, so there is no question of this being excessive. Now, is it always successful? Again, here we have a problem. Now, when your probing depths are this deep, when you reach this 9-10 millimeter mark, even after open flap debridement, you can get it down to maybe 6. Okay, you can get 3 millimeters or more, not more than that. Now, with that 3 millimeter recession, where drop in probing depth itself, you still have a residual probing depth of 6 millimeter, which is too much. Right? So, success at pocket management depends on the stage at which the pocket is diagnosed. Diagnose it at 4 to 6 millimeter category, success is good. Diagnose it at beyond 8-10, the success starts dropping. Right? Again, the success of periodontal therapy for a pocket depends not only on the perio skill, but on the general dentist who's spotting this early enough and referring it to the perio. But because the early pockets don't exhibit many symptoms. So if you were to actually examine every patient and see if pockets exist, you might be able to identify them at a stage where there is no need for a flap, do root planing and finish the therapy and be done with it. Okay. So like I said, all this is only disease progression. You are not regenerating. Now we know this. Regeneration works in furcations like this. Okay. Vertical defects like this. Okay, this one is a shallow vertical defect, won't do too well. This one is a deep vertical or deep intravenoid defect, will do well. All right, like I said, we know it does well in terms of bone regenerating. Histologically, you're not going to get back acellular cementum and perpendicularly oriented periodontal ligament fibers easily. But that does not mean treatment is a failure. As long as you have achieved pocket reduction, which is more than the 4 to 5 millimeter mark, as long as you have prevented inflammatory disease, treatment is working well. Okay, I repeat, you're not replacing pulp, you're not regenerating pulp. By doing root canal treatment, you are taking off vital pulp and putting non-vital cataparchat. Do not forget that. So don't go around telling the general dentist that histological success with regeneration is low. That is not what the patient is worrying. Patient is not worrying about, has my cementum come back? Has my periodontal ligament come back? Am I going to lose my teeth? Am I going to be able to eat well with the existing teeth? Now that does not require cementum and periodontal ligament regeneration as long as the bony defect is like this. Right? Again, see the same thing here. Again, a furcation involvement. Again, regeneration possible. As you can see on the radiograph. All right, now, so far we've said. So what have we said all this while? Treatment seems to be excessive for the patient and sometimes for the general dentist also when actual periotherapy is suggested. So what our perio fellows seeing over a period of time is, what is this? When I start telling treatment that is actually required, people are not wanting to do it. They are thinking it is excessive. Okay, so over a period of time, our fellows have gone on to game plan 2. Right? So they will say, when a patient comes like this, start doing laser therapy, start doing root planing, start doing that, this, whatever. So for this fellow, the treatment will be very, very successful and everybody is happy as long as they are willing to pay the money, because this is always going to do well. It is very reversible. Scaling alone is enough. Okay, so that is plan 1, excessive treatment. But with excessive therapy, in this patient, everybody is happy. Or plan number 2, patients are not able to appreciate the probing depth difference. Patients are not able to appreciate the patients are not able to appreciate that bone has gone back, and I am having to make this decision tree for intravenoid defects. You can see this. So obviously it is not an easy decision tree to go through, and this is the current literature where they are saying regeneration is still possible, But again, histological evidence is not very high, so we have to wait and see. Okay, so what our periodontal brethren are thinking is, if we tell the facts, patients are not happy. Sometimes the general dentist is also not happy. If we treat excessively on treatment, on gingival inflammation where no other treatment is required, everybody is happy. So let me go and do another visible treatment. So a fellow comes like this. Don't attempt to save it. Don't attempt to regenerate, because now furcation is unpredictable. Let me extract this tooth and place an implant in. So now there is no complaint because the patient is able to appreciate a new tooth has come. The clinician is very happy because now implant is given him the EMI for the OD. The periodontist is also happy because for the first time in his life, both the patient and clinician is happy. Okay, so this is the reason why you will find that there are many periodontists who are preferring implant therapy over basic periotherapy even. There is no need to speak about the other dentists at all. Okay, at the time when I started my perio work, this furcation was never identified. So nobody bothered identifying furcations on radiographs. Today, everybody does. The prosto identifies furcation, the oral surgeon identifies furcation, because now furcation means you extract the tooth and place an implant in. For that sake, they identify the furcation. The endo also has started identifying the furcation, because the endo will say now the reason why root canal is failing is because of the furcation. So now this furcation has meant, it has become something which means periodontal treatment will not work. And in case there are non-periodontists listening to this, let me remind you, people like Hirschfield, Wasserman have shown 18 years of successful therapy of furcation grade 2 management. Yeah, they have followed up teeth for more than 18 years after regeneration grade 2 furcations and found it to work well. They have found that treatment for grade 3, as long as it is in the early vertical bone loss stage, again successful up to a period of 8-10 years. Okay, so do not think that furcation means death. It is no such thing. Furcation grade 2 is managed well. Furcation grade 3, even in its early vertical A stage, it is managed well. Vertical bone defects, if they are 3-walled, 2-walled, are managed well. It's not that all those defects don't get managed. There is no need to extract all of them and place implants for all of them. Okay? That is actual excessive therapy. So although the clinician and the patient may be happier with the option, the real excessive therapy that you will find in the field of periodontology is when periodontally manageable teeth, or teeth that were managed periodontally historically, have started getting extracted and implants have started being placed there. Okay, there is an international journal of restorative and periodontal dentistry. Around 5-6 years back, there was a long editorial from the editor-in-chief, which was titled "The Decline and Fall of the Perio Empire." So he was reporting how even in the European and the American continents, the same thing is happening, that more and more teeth are being extracted when there is no need, because the periodontist is at last happy that both the clinician and the patient is seeing some visible effect of treatment. Okay, because everybody can see an implant, everybody can see a new tooth being placed, whereas they are not able to see the outcome of pocket management and vertical bone loss. Right? So that is the real tragedy that we are facing. So the long and short of this is, periodontal therapy in itself can be successful without being excessive, as long as the clinical diagnosis is done at the right stage and the proper treatment is instituted. When the patient is actually educated about what periodontal disease is and what its management entails. No periodontal treatment is going to work well in the absence of patient maintenance. Okay? Patient is very much part of the treatment. It is not like it is for hypertension, like it is for diabetes. Same for periodontitis. Okay, with that, thank you all.
Thank you, sir. I wish there were many practitioners who were in this group, because you told us an extensive way of practicing. Can we just give the floor to the other two panelists?
Please.
Dr. Jayashree, Dr. Anita, would you like to tell us your comments?
Good afternoon, everybody. Can you hear me, ma'am?
Yes, ma. Yes, we can hear you.
Good afternoon, everybody. It was a very enlightening talk by Dr. Arun on whether periodontal therapy is success or an excess from the general dentist point of view, as well as the patient and the periodontist. It was an elaborative talk. And now I would like to highlight what he said. He has done it in a picturesque manner. I would read it out in words. Now, periodontal therapy has evolved with the use of growth factors, periodontal regeneration techniques, modification of various flap designs, and use of dental implants with rich augmentation procedures, thus making the specialty reach beyond the preset horizon. The internet has become a library of knowledge with regards to periodontal procedures. Yet knowledge of periodontal diagnosis and treatment planning is restricted to bachelor programs. Early diagnosis is key to successful periodontal disease management. By engaging in a vicious cycle of performing oral prophylaxis and delaying referral for several years, general dental practitioners indelibly lead to referrals with compromised periodontium. Mandatory periodontal examination in addition to routine oral and dental examination is necessary to diagnose and treat periodontal disease at its incipient stage. Patients will thus benefit from specialist periodontal care. The minimal parameters for determining a periodontal diagnosis are age, bleeding on probing, clinical attachment loss, tooth mobility, furcation involvement, 6-point measurement of periodontal probing depths, and percentage of radiographic bone loss. These parameters need to be incorporated as part of a holistic diagnostic examination, and intraoral periapical radiograph should not be the sole assessing tool as most general practitioners use it. This in turn enhances the quality of periodontal treatment, which is hugely diagnosis driven. Implementation of treatment is as follows. First, the patient education, then the scaling and root planing, which is the gold standard and basis of all periodontal treatment. Third is the local or systemic chemotherapeutic therapy, and then the re-evaluation of the patient clinically. Referral to a specialist for further management of conditions of gravity like periodontal diseases associated with systemic conditions, gingival overgrowth, enlargements, resective surgery, regenerative procedures of hard and soft tissues, perioplastic surgery, pre-prosthetic procedures, occlusal therapy, dental implants is warranted. It is imperative to involve the patient while diagnosing periodontal conditions, like using a mirror to help them visualize gingival bleeding, swellings of gingiva, recession, furcation involvement, tooth mobility, and pus discharge. They should be made cognizant of the numerical values of probing depth and clinical attachment level, and the bone loss depicted in radiographs, which should be displayed against radiographs of healthy periodontium to understand the stark contrast between the two. Thus, embracing patients' active participation will arouse their interest in their own dental and periodontal. This in turn makes educating the patient and available treatment modality easier in subsequent appointments with the periodontal specialist. Thus, to summarize, it is high time for periodontics to move from the backyard of obscurity to the venue of necessity. Initial issues of disease might be trivially disregarded by the general dentist, deeming periodontal treatment at their stage to be excessive. It is quintessential time to intervene to yield successful results. So you will have to, the diagnosis will determine whether the periodontal therapy is a successful management of the periodontal disease, or the patient thinks that it is excessive from his point of view. So I want the general dentist to have a good diagnostic tool in their armamentarium and then proceed with management of periodontal disease.
Thank you, ma'am. Thank you for enlightening us. Now, actually, before we proceed on to the next panelist, we have Dr. Rajesh Pal from a cardiovascular surgeon from Royal College of Surgeon, Edinburgh, to tell us about the conference that he's going to have between October 6th to 8th in Chennai. So, and he's at an odd hour of the day. So we will give him the mic first. After that, we'll go back to the panelists, sir. Please, Rajesh Pal, sir.
Unmute myself.
Yes,
Thank you very much, Dr. Kala. Thank you.
Thank you, sir. My pleasure.
I just wanted to say that I got in a bit late because the capacity was full. And I am really pleased to be available today to participate, albeit shortly. And I just wanted to inform the gathering there that the first international conference overseas from the Royal College of Surgeons of Edinburgh is going to be held in Chennai, my hometown, where I graduated from the Madras Medical College in 1973. We have a large dental session in the meeting, mainly to inform all of our dental colleagues in Chennai that there is the largest dental faculty in the Western world is in Edinburgh. So I would want to extend a personal invitation to all of you who are present today to join us to enrich yourselves and ourselves in the Faculty of Dentistry. The conference is going to be held in the Grand Chola, and if you visit our website, which is available for every one of you to have a look at, to see which day the dental session is going to be held, and please participate with us. It'll be an honor and a privilege to share your knowledge with us. Thank you very much.
Thank you, sir. So it's an open welcome for all of you. Definitely there will be a bilateral session. And as he said, both of us can gain. So you're welcome. It will be on our website and Royal College of Surgeons. You can see it's already there and you can participate. Yes, sir. You're welcome to your homeland and Chennai.
Thank you so much. Thank you.
Over to the next panelist.
Thank you, ma'am. Am I audible? Hello, am I audible? Okay.
Yes, ma'am. Yes, ma'am.
Yes, okay. So thank you, Dr. Arun, sir, a well-known speaker in the country, a well-known periodontist all over the country, for giving an excellent enlightenment on the statement that periodontal therapy is a success and never an excess. So defining success in medical field is objective, dynamic in nature, based on the criteria used to determine a positive outcome. Certain specialists like Lang and Bartol, well-known people in periodontology, in 2018, they stated that, as reported in 2017 World Workshop, achieving a pristine clinical health is practically impossible. So the reduction in probing pocket depth and clinical attachment level or loss are the two criteria defining periodontal treatment success. Over the years, periodontal treatment has evolved and the ability to maintain natural dentition has become the priority. Bartol in 2018 reported that the future success in periodontology has changed a new approach in which precision medicine, in which genome, environmental factors, the lifestyles of the individual are also taken into consideration on success. Prini Prato and Tonetti in 2017 stated that outstanding outcomes achieved with regenerative techniques represents a call for tooth retention these days, rather than tooth extraction that was practiced earlier. Today, the criteria for success of periodontal therapy should include treatment and re-evaluation of a severely diseased tooth before considering extraction, reduction in the tooth loss rate, that is the focus of a general dentist, long-term documentation of periodontal stability, and patient satisfaction with improvement in the quality of life. I thank the Tamil Nadu M.G.R University, the Registrar and the Vice Chancellor for giving me an opportunity to moderate this session. Thank you.
There are any questions from audience? If there are any questions from audience? If not, then we can call it a day. 1 minute, let me check if there are any questions in the chat. Yeah, there is a question. So Pravina has asked, what could be done if there is severe abrasion on the cementum? Dr. Arun, sir?
Okay. So the right, am I being audible?
Yes, sir.
Yes. Less than 2 millimeters. Okay, I repeat, if the step defect is lesser than 2 millimeters, restorative and perio to be done together. Does that answer the question? You want details?
1 minute, sir. 1 minute, sir. No, sir, there is only one question, sir.
Okay.
If there are no further questions, then thank you very much, Dr. Arun, sir, for having you here for the webinar. Thank you very much. We will meet in the next session, that is on 26th September, Friday, 4th Friday. 23rd September. Thank you very much, sir. Thank you, sir. Thank you, Dr. Anita, madam.
Thank you, ma'am. Thank you, ma'am.
Jayashree, madam. And thank you, Dr. Rajesh, for joining us.
Thank you very much indeed. Thank you, Professor Arun, for your erudite presentation.
Thank you, sir. Thank you. Lovely to hear from you.
Okay, sir. Then we will end the meeting. Thank you very much.